and the recording is um, starting. So once again, I'm Dr. Brown, as I said before. I'm the medical director here at Avinia, and we have this case study program for all practitioners in the state of Georgia, as we're required to provide them with pharmacology training, but it's open to practitioners, MPs, and PAs all over, as well as facility staff, mental health and primary care all over. Today, the case study will be um, today the case study will be um, on opiates, um, opioid use disorder, as well as persistent depressive disorder. So, and I'm just checking to see if there's anybody else that needs to be added. All righty. So I'm gonna go ahead and jump in. I got a little bit of a cold, so y'all bear with me. My voice is it's not a little nasal, it's a lot nasal, but I'm gonna trudge through this. So let's go ahead and get started. And also, if I'm gonna stop every so often and ask you if you have questions, y'all can speak out verbally. No one is muted, and there also is a chat function that you can chat your question in, and I'll check the chat every so often. Um, and particularly if I ask you if you have any questions as I stop. So the case study is Opiates Are Running My Life, and it's from a textbook, Psychiatric Case Studies for Advanced Practice. The authors are Kathleen M. Prendergast and Casey Jackman. And there are also two other books, and I'll mention their names when I get to them for questions. Um, but identification: a patient's a 28-year-old single white male who lives with his biological parents. He is seen for psychiatric evaluation at a private psychiatric outpatient practice. The chief complaint: I need serious help to stop using heroin and opiates. It's ruining my life. Um, History of the chief complaint: the patient returned from 9 months in a rehab and halfway house program in Florida. Within 4 months of returning, he ran into an old female acquaintance, and I ended up in my old haunts and started using again. Let me see here. I've got somebody else waiting to come in. He reports using 4 to 5 bags of heroin intravenously on a daily basis. His last use was 2 hours prior to the appointment. Past psychiatric history: the patient reports being diagnosed with attention deficit hyperactivity disorder in the 5th grade. He believes that he was prescribed mixed amphetamine salts, extended release methylphenidate, and possibly amoxicillin between the 5th to the 8th grade. He reports, I didn't like taking them. They made me spacey. I used to hide them. He never had any inpatient or outpatient psych treatment, and his medications were prescribed by his family practitioner. When in his first rehabilitation program at the age of 25, he was diagnosed with depression and started on fluoxetine, but stopped it abruptly after discharge. I just never got it refilled again, he states. I was depressed since the breakup of my new engagement. I don't want I don't think I've really gotten over it, and maybe the drugs help to numb my feelings. So we have an issue with some depression. It looks like the depression may predate the opioid use. During his rehab in Florida, um, 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 no, it looks like the depression postdated his opioid use, but maybe a totally separate um, um, condition. But during his rehab in Florida, he was diagnosed with opioid use disorder and major depressive disorder. He was prescribed Remeron for depression, and off-label for the insomnia, and quetiapine off-label for. These medicines continued upon his discharge and return home. And despite his relapse, the patient reports continuing to use the medications because he states that they really help me sleep and I feel better with them. I just got to stop using. So, does anybody have any questions right here about the history so far? You can chat. You can hit the chat, or you
I have a
can.
question.
Mhm.
He said he was given Seroquel for what exactly?
He was given the Seroquel for sleep
With the mirtazapine?
with the mirtazapine. Yeah, in this case, I don't.
Hmm.
It seems odd,
Okay.
but
Yeah, it
um,
is.
they should have just gone up. But he was already. I think the maximum dose on mirtazapine is 45 milligrams. So he's at the maximum dose. He still had some sleep issues, so they went on and gave him some Seroquel to top him off. Any other questions from anybody? Let me see if I can check this chat function here. Uh, all right. No, I don't see any questions from the chat function. But anyway, speak out or chat. I'll go ahead and keep on going. And got some more people coming in here. All right. Medical history. The patient suffered a concussion at the age of 17 in an ice hockey game. He believes he lost consciousness for about 2 minutes. He was evaluated in the emergency department of a local hospital and given a CT scan. The CT scan was negative, and he was discharged to home. He denies any history of seizures or recurrent headaches or visual disturbances. He has no chronic illnesses. He has never had surgery or been medically or psychiatrically hospitalized. He has no known medication, food, or environmental allergies. His present medications include Remeron 45 milligrams at bedtime and quetiapine 200 milligrams at bedtime. He reports adherence to these medications, and this was confirmed by the pharmacy's prescription fill record. He did undergo a limited physical examination. Um, as the patient reports, his last IV heroin use was 2 hours prior to the appointment, and a clinical opioid withdrawal scale, COWS scale, was administered, and his COW scale was 0. And let me go talk about the COW scale real quick so you'll understand it. It's a Wesson and Lane clinical opiate withdrawal scale, COWS. The clinical opiate withdrawal scale is an 11-item scale designed to be administered by a clinician. The tool can be used in both inpatient and outpatient settings to reproducibly rate common signs and symptoms of opiate withdrawal and monitor these symptoms over time. The sum score for the complete scale can be used to help clinicians determine the stage or severity of opiate withdrawal and assess the level of physical dependence on opioids. Um, Practitioners sometimes express concern about the objectivity items in the cows. However, the symptoms of opioid withdrawal have been likened to severe influenza infection, nausea, vomiting, sweating, joint aches, agitation, tremor, and the patients should not exceed the lowest score in most categories without exhibiting some observable sign or symptoms of withdrawal. And that just means that it's sensitive. So if you have something going on, you'll get scored. If not, you shouldn't. But the 11 points are resting pulse rate, sweating, restlessness, pupil size, GI upset, tremor, yawning, anxiety or irritability, bone or joint aches, runny nose or tearing, and goose flesh. So these are the 11 dimensions that you or symptom sets or physical signs that you evaluate in this scale. So he has a zero, so he's not in any withdrawal at all. But he just had his last hit 2 hours prior to the evaluation. The vital signs are heart rate 68, respiration 16, temperature is 98.4, blood pressure is 108 over 62. The patient presents as calm, cooperative, without restlessness or tremors. His pupils are constricted as they should be. He just had a hit. Skin is smooth. With there are track marks on his forearms and hands bilaterally. The patient denies any pain, cramping, or nausea and exhibits no congestion or lacrimation. I'm gonna go ahead with the history of drug and alcohol abuse, and then we can stop, and I'll let you ask some more questions. The patient reports smoking marijuana a couple of times in high school and in his early 20s, but smoking weed and drinking was never his thing. Around the age of 24, the patient reports being given oxys at a party, and he says, "I found my thing. I felt relaxed. I could be social." His use of the oxy codon escalated to 15 to 20, 30 milligram tablets per day. And when without the drug, he reports experiencing nausea. He reported experiencing nausea, shakes, and chills. By the age of 25, and having had withdrawal symptoms of at least 4 to 5 times in the prior year, he entered his first detoxification and rehabilitation program, which lasted 28 days. He remained clean for about 8 months and then started using the oxycodone again. I realized that the pills were expensive and the heroin was cheaper. At first, I started snorting it, but once I injected, the high was nothing like I ever experienced before, and I just needed more of it. The patient reports increased use from 3 bags of heroin per day to a bundle, which is 10 bags, or more over the course of the next 6 months. By the age of 27, he says he was a mess. I couldn't hold a job. I had fights with my parents. I never saw my friends. I checked into rehab and begged them to send me for long term. The patient completed a local 30-day rehab program and then went to Florida for a 90-day program, followed by a halfway house for 6 months. The patient has been abstinent for 4 months, then began using 4 to 5 bags of IV heroin again about 2 weeks ago prior to this appointment. And that's when he ran into an old girlfriend who triggered him. Any questions thus far, or do we need any more information to start wrangling this case down? Anybody think we're missing anything? Does the evaluator need to get more information regarding the history of present illness?
I have a question. I didn't hear anywhere where he was given any type of outpatient support after he was discharged, or even some sort of treatment for the opioid use disorder. They didn't try anything for him. What was
No,
the
no,
treatment?
it was just detox and go hang in there, which is probably the break, the bad break in the whole treatment plan. They didn't offer him any long term. They didn't even make a
Support.
recommendation for him to go to NA or even get his family involved, or
Right.
send him to
That's what I was wondering.
a program. But once again, these guys are about detox. So if you were thinking, should they have sent him to a methadone maintenance or a Suboxone clinic? Obviously, that wasn't the case because he was clean and he'd been clean for some time. It's just that he didn't have any psychosocial support or psychotherapy, to kind of help him stay clean. And obviously, when you go back to your same environment, you're gonna encounter the same things, and because that doesn't change. obviously you have to. So, um, any other questions? I went to the chat section. I don't think I saw anybody asking any questions. Actually, if you ask your questions verbally, that's a lot easier. So, uh, if everybody's good, I'll keep going. I'm going to go on to the family history now. The patient was raised by his biologic parents, with whom currently resides. His mother's 56. Um, she smokes cigarettes and is diagnosed with anxiety, for which she is prescribed Celexa 20 milligrams daily. She works in a manufacturing company. His father is 64 years old and retired from his teaching position at 35 years. 2 years ago, his father was diagnosed with early onset dementia, but has been refusing any treatment. The patient reports, I'm scared to drive with him. He gets lost and has no reflexes. He doesn't pay attention when there's a red light or stop sign. And the patient also reports he would drive me to the city to go get my fix. So I guess it wasn't that bad. But my mom would just yell at both of us and state, I can't take it anymore. The patient has an older sister. She's 34 years old. She's a heavy drinker. Every time we have a family get together, she's drunk. She lives with her boyfriend of 10 years. She also has a 30-year-old. The patient also has a 30-year-old brother who's married. He has two children. He has a daughter age 5 and a son age 3. Gotta admit somebody. Um, uh, and he's supposedly the normal one in the family. All right. The patient's relationship with his family members are strained since he began using opiates and then the heroin. Sometimes they're supportive and seem like they want to help me, he says, but most of the time they just tell me I'm a junkie and I need to get over it. Um, None of his family members attend Naranon um, or any of the other family support meetings. So he doesn't have much family or social support. Got some more people to admit. All right, let's go over the personal history, and then I'll stop and let you ask some more questions. Personal history, perinatal childhood, there are no abnormalities or complications. Adolescence, the patient's a high school graduate, average B's throughout high school. He was active in playing ice hockey until his concussion at the age of 17. Adulthood, at the age of 24, the patient was engaged to his girlfriend of 3 years. The relationship ended when she cheated with one of the patient's good friends. The patient reports he suffered from depression since that time, but has not sought treatment other than through the substance use programs.
With all kinds of animals. You're going to read from page 62 to 75
Oh,
silently.
someone's talking. Like, already, I just muted everyone. Um, at the age of 24, the patient presently is single and and the patient is presently single and is not involved in any relationships. He identifies as heterosexual. At the time of his engagement, the patient was completing courses for certification as a massage therapist. He completed the program but never took the certification or licensure examination. He averaged B's throughout his master's massage therapy program. He is currently unemployed, but works odd jobs that my friends get me underneath the table. The patient has had three legal charges over the years. He was charged with loitering, solicitation of controlled dangerous substances, and reckless driving. All of the charges occurred while the patient was intoxicated. Though the drug screening was never done at the time of his arrest, the patient completed his community service hours and has paid his fines. He has 6 months of probation left and must remain abstinent to avoid any incarceration. He has state-based medical insurance and is not on any disability. Trauma abuse history. He denies any history of any physical, sexual, or emotional abuse. So I'm going to stop here. Does anybody have any questions about the history? The next section is the mental status exam. But are there any questions about the historical data? All right, let me check the chat. See if anybody has any questions.
Did you unmute us?
No, I didn't mute you. So I can hear you. I unmuted you, and I just heard you talk. So let me check the chat. See if anybody has any questions. No questions in chat. We'll go on to the mental status. Mental status examination appearance. He's a neatly groomed 28-year-old single male who appears to stated age. Behavior and psychomotor activity. He's cooperative, easily engaged, no restlessness or abnormal movements. He has good eye contact throughout the exam. Consciousness. He's awake and alert. Orientation. He's oriented to person, place, time, and situation. Memory, short and long term memory, grossly intact without deficits. Concentration and attention, adequate for purposes of the exam. Some questions needed to be repeated, however. Um, Visual spatial ability, this was not assessed. Abstract thought, he was able to interpret don't cry over spill milk as no sense in crying once something's over. Intellectual functioning, he appears to be of average intellect, good vocabulary, and sentence structure. Speech and language, his speech is of normal tone and rate, with occasional brief 1 to 2 second delays in responses. Perceptions, um, there's no evidence of responding to any internal stimulation or altered perceptions. Patient denies any hallucinatory experiences both while being intoxicated or while being clean. Um, Thought processes, these are logical, goal directed, and future oriented. Thought content, the patient um, focused on wanting to recover and remain abstinent from the drugs. Suicidality or homicidality, the patient denies any current or past suicidal or homicidal ideations, plans or intent. The patient denies past or current aggressive and self-injurious behaviors as well. He denies that he has use of drugs. He denies that he has used drugs in any way to attempt to harm himself or kill himself. His mood is dysphoric and anxious. His affect is congruent with his mood. Impulse control is adequate, except when trying to avoid using drugs. uh, Judgment, insight, reliability. The patient's a good historian, and he presents as genuine and honest. So, any questions about the mental status examination? Anything you'd like to ask about it? Any concerns about it? Seems to be a pretty routine mental status examination, especially for a guy that just used a couple of bags of heroin. So he must have some some high tolerance because he's not really sleeping. He's interactive, so he's strongly dependent. Just by that. Any questions before I move on to the formulating the diagnosis? All right. Well, we'll go on to formulating the diagnosis. Which diagnosis or diagnoses should be considered? And friends, we have three of them here. We have opioid intoxication um, without any perceptual disturbances. We also have opioid use disorder, severe, number two. And then we have a third one, which is persistent depressive disorder, which is dysthymia. Okay. Let's go ahead and look at the criteria for opioid intoxication. All right. Um, Diagnostic criteria: A, there has to be a recent use of an opioid. We check that box. B, clinically significant problematic behavior or psychological changes. Initially, examples are initial euphoria followed by apathy, dysphoria, psychomotor agitation or retardation, impaired judgment, and all these develop during or shortly after the opioid use. Uh, Next criteria: pupillary constriction or pupillary dilatation due to anoxia from severe overdose with brain death. Um, and one or more of the following signs or symptoms developing shortly or after opioid use: drowsiness or coma, slurred speech, impairment in attention or memory. I think our guy during exam, he just had pupillary constriction. So, like, once again, he has some high tolerance because he wasn't slurring or sedated, and his attention seemed to be intact. Um, but he still had some heroin on board. Criteria D: the signs and symptoms are not attributable to any other medical condition and are not better explained by another mental disorder, including intoxication with another substance. So those are the criteria for opioid intoxication. He was intoxicated, but once again, he has high tolerance, so he didn't display a significant amount of these criteria. Let's move on to opioid use disorder severe and its criteria. Criteria A: a problematic pattern of opioid use leading to clinically significant impairment or distress, as manifested by at least 10 of the following um, occurring within all occurring within a 12-month period. One, one, the opioids are often taken in larger amounts or over a longer period than intended. There's a persistent desire or unsuccessful efforts to cut down on the um, on the or control the opioid use. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover from its effects. There's craving or strong desire to urge. There's a craving or strong desire or urge to use opioids. Um, there's recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the opioids. Seven, important social, occupational, or recreational activities are given up um, or reduced because of opioid use. Eight, recurrent opioid use in situations in which it is physically hazardous. Um, Nine, continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the opioids. And 10, which is important, is tolerance. And this is defined by either of the following: a need for markedly increased amounts of opioids to achieve intoxication or the desired effect, or a markedly diminished effect with the continued use of the same amount of the opioid. And there's withdrawal, as manifested by either of the following: the characteristic opioid withdrawal syndrome, which we've discussed, and opioids are closely related substances. Other opioids or other closely related substances are taken to relieve um, or avoid the withdrawal symptoms. Okay, so and that's the criteria for opioid use disorder severe. Now, what's the rationale for both of these diagnoses, opioid intoxication and opioid use disorder? The patient reports the last use of IV heroin 2 hours prior to the appointment. Um, Pupils are pinpoint and constricted with no associated withdrawal symptoms. The patient has struggled with heroin addiction over the past 4 years and has been unsuccessful with abstinence for greater than 8 months. His use has escalated over time and interfered with family relationships and work. His use is associated with legal consequences, currently on probation, and his opioids have been taken to relieve withdrawal symptoms. And I'll go ahead and stop here before we go to the evaluating the next diagnoses. Um, any questions about the diagnosis of opioid intoxication and opioid use disorders in this patient? It's pretty clear and evident, that he meets the criteria for these diagnoses, just just based upon his history. Um, I'll go on to the additional diagnosis of dysthymia, or what's now called persistent depressive disorder. The diagnostic criteria is this disorder represents the consolidation of uh, chronic major depressive disorder and dysthymic disorder. And this is from DSM-4. Um, those were just combined in DSM-5 to become persistent depressive disorder. First criteria: the patient must have a depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others for at least 2 years. And in children and adolescents, this can be an irritable mood, and the duration has to be at least 1 year. So 1 year in kids, 2 years in adults. B, the presence, while depressed, of two or more of the following: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. Criteria C, during the 2 year period or 1 year period for children or adolescents of the disturbance, the individual has never been without the symptoms of criteria A or B for more than 2 months. So this is pretty continuous, and it's just ongoing, and you shouldn't have more than a 2 month break of these symptoms. The criteria for major depressive disorder can be made continuously in this disorder. So you can have a major depression develop on top of this mild depression, and they call that a double depression. And the way you distinguish between dysthymia and major depressive disorder is really suicidality or feelings of harming yourself. You generally don't have that in dysthymia, but if it becomes that severe, along with the really hardcore neurovegetative symptoms, you can say that the person has entered a phase of major depressive disorder on top of their dysthymia. Criteria E, there's never been a manic episode or a hypomanic episode, and the criteria had never been met for cyclothymic disorder. F, the disturbance is not better explained by persistent schizoaffective disorder, schizophrenia, delusional disorder, or any other specified or unspecified schizophrenia spectrum and or a psychotic disorder. And G, the symptoms are not attributable to the physiological effects of a substance, drug of abuse, medication, or other medical conditions such as hypothyroidism. And H, the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. So, I mean, some could say here that maybe his depression is related to his opioid use, but he had been clean for several months and doing still doing well on the antidepressant medication, um, and but he still had some symptoms of the dysthymia. So, because of that, it looks like he had two separate disorders, and the opioid wasn't a cause of his depression, but was uh, just attended to it. Let's go over the rationale for this diagnosis of persistent depressive disorder, and then I'll let people ask some questions. This disorder is presently in remission due to the psychopharmacotherapy. That's the Remeron uh, that he's on, um, uh, which is continued despite the patient's heroin use. Um, the depressive symptoms have been less severe and without suicidality. Um, the symptoms have persisted for longer than 2 years. Prior to beginning medications, the symptoms included fatigue, insomnia, poor appetite, anxiety, and feeling hopeless. They have interfered with his work, his family, and his relationships. The symptoms returned after the patient's first use uh, of an antidepressant was discontinued. So when he stopped his medicines, the antidepressants, he developed the dysthymic or chronic depressive symptoms once again. So anybody got any questions about persistent depressive disorder in this case as a primary disorder? All right, it's just a mild depression, 2 years in running, in adults. It doesn't get to the level of being suicidal, but there are some mild neurovegetative symptoms, and it's just continuous. And there's no more than a 2 month break in the symptomatology. And most importantly, it needs to be treated with pharmacotherapy. Okay. Any questions? Alrighty. What tests or tools should be considered to help identify the correct diagnosis um, in this patient? Obviously, COWS, the opioid withdrawal scale, was used to rule out any opioid withdrawal symptoms versus intoxication. And then for the dysthymia or persistent depressive disorder, you could use the Hamilton depression scale. Next point, what differential diagnoses or diagnosis should be considered? And the one we have here is actually a substance-induced depressive disorder, um, with opioid use disorder being the culprit. Um, this disorder is characterized by depressive symptoms developing during or shortly after substance intoxication or withdrawal from the opioids. But for this patient, the depressive symptoms historically occurred separate from the substance use. So it looks like his depression was not secondary to his substance use, but was actually independent from it. Okay, y'all hanging in there with me? We're gonna now talk about formulating a treatment strategy. All right, what treatment would you prescribe, and what rationale? What is and what's the rationale? All right, we're going to start off with psychopharmacology in treating this case. All right, since the patient has never had a trial of medication-assisted treatment for opioid use disorder, he is a good candidate for this treatment. Um, the risk and benefits of naltrexone extended release injectable suspension, which is Vivitrol, versus buprenorphine naloxone, which is Suboxone, should be discussed with the patient to determine which medication assisted treatment option is best for this individual. In this case, the patient chose naltrexone extended release injectable suspension. Now, both the naltrexone and the lanoxone are antagonists, and they block that mu receptor which the opioid hits. So, uh, once again, it looks like he's going to choose to go cold turkey and not have anything agonize that receptor. Whereas the buprenorphine, the Suboxone contains some buprenorphine, which actually is a mild agonist of the mu receptor, and it would provide some opioid agonism or stimulation, and he would still feel a little high, but it's mixed with the naloxone, so he doesn't get the euphoria that he would get from it. So, but he's gonna. It sounds like he just wants to block his receptors altogether, and we can talk about that more if you have some questions. So, in order to prepare the patient for outpatient medicated medication assisted therapy using naltrexone extended release injectable suspension, um, the patient must be opioid free for 7 to 10 days to avoid any precipitous withdrawal. An at home detox program using prescription and over the counter medication to reduce the discomfort of withdrawal will be offered, and the patient's mother is willing to supervise an at home detox program, and the patient is willing to commit to this in home protocol. So, once again, he's going to shut it down, get off all the opioids, go through a detox at home so he can be placed on the Vivitrol. The following combination of medications can be used to relieve the discomfort of withdrawal symptoms over a 5 to 10 day period, uh, with a progressive decrease in the frequency of dosing. The patient should be encouraged to rest and drink plenty of clear liquids, eat as tolerated, and be out of bed as tolerated. And then this is the medication regimen for his at home detox. Clonidine, zero point 0.1 milligram, 1 tablet every 4 hours is needed for elevated blood pressure and flushing. Hydroxyzine, 50 milligrams, 1 tablet every 4 hours is needed for anxiety, agitation, and insomnia. Ibuprofen, 600 milligram tablets, 1 tablet every 6 hours is needed for aches and pains. Dicyclamine, 20 milligrams, 1 tablet every 6 hours is needed. Every 6 hours is needed for abdominal cramping and nausea. Diphenoxylate, 2.5 milligrams slash atropine, 0.25 milligrams, 1 to 2 tablets every 6 hours is needed for diarrhea. Once the patient has been opioid free for a period of 7 to 10 days, then the next phase of pharmacotherapy can begin. Um, I'm going to keep reading through this, and then we'll talk about the the wiseness of using this particular strategy in this patient. But let me finish up. Now, trucks. Once the patient has begin, once the patient has been opioid free for 7 to 10 days, the next phase of psychotherapy can begin. So when he comes back, he can start. When naltrexone, or Vivitrol, 380 milligrams IM every 4 weeks. The patient must be opioid free for 7 to 10 days prior to receiving his first injection of Vivitrol to avoid a precipitous withdrawal, which may be severe enough to require hospitalization. A urine a drug screen should be completed to determine that the patient is opiate free prior to initiating treatment with naltrexone or Vivitrol. Um, Naltrexone will be administered as an IM gluteal injection, alternating butt cheeks with each subsequent monthly injection. Additionally, the patient will continue on the previously prescribed medications to maintain remission of his depression and insomnia, which is the quetiapine 200 milligrams, one tablet at bedtime for insomnia, and Remeron 45 milligrams, one tablet at bedtime for depression and insomnia. As the patient has a history of relapse, the following should be included in his treatment plan. Uh, the Narcan, um, 4 milligrams per 1/10 cc nasal spray, or naloxone 0.4 milligrams auto injector, and you administer the auto injector into the thigh or one spray into each nostril as needed for suspected opioid overdose. And if this is if the patient is unresponsive, the respirations are markedly slowed, and immediately contact emergency services at 911. So, how many people think that this at-home detox program is a good option? Anybody have any comments about that? It seems a little cavalier to me. Do y'all think that this guy could make it with his history with an out-home detox?
I
I thought
don't
I
think
don't
so.
think it's a
I
good idea.
Yeah, that's not realistic, is it? Yeah,
no.
he's not gonna make it. No, he's not gonna make it. He's not gonna make it. He's gonna go out and use again, and when he comes back to get his Vivitrol, his drug screen is gonna be positive, isn't it? 9 times out of 10. He has poor family support.
Okay, did you
He
get
he
me?
just he's not in the
Oh, okay. Okay.
he's not in the right environment um, to be detoxed. The old girlfriend, the mom, the sister who drinks, the dad who has dementia, and actually takes him to go pick up his drugs. It's not a good look. So this guy probably would need to be in a if they have a partial hospitalization program, or just fully hospitalized for his detox. I think that would be his best bet. But I just wanted to, take y'all over how even in the hospital they would run him through this same routine. So inpatiently, or in a residential program, he would undergo the same regimen to get off. But I would definitely not put this responsibility in the hands of his mother. Okay. Uh, let's go over some of the diagnostic tests that should be used. Routine laboratory tests, including liver function tests, should be drawn, as liver dysfunction has been associated with um, uh, Vivitrol. Thyroid function tests, uh, TSH, thyroxine, and triiodothyronine should be measured, uh, um, because these abnormalities here may result in ongoing depression. A lipid panel and a hemoglobin A1C should be monitored, uh, um, given the use of the quetiapine, and a supervised urine drug screen should be conducted to ensure the patient's abstinence from opioids and other drugs as well as alcohol. And it says here during the patient's in home detox, the patient and family members can use the cows to monitor the patient's withdrawal symptoms. But I think, putting that responsibility on the family, it's not malpractice, but it's not good practice. I wouldn't have his family. He just doesn't have a responsible family. Referrals: if abnormalities appear in the laboratory studies, the patient should be referred to his PCP or an associated medical specialist to treat the medical condition. And here's the most important thing: the patient should be referred to a 12-step um, facilitation program, Narcotics Anonymous, or alcohol or AA to support his recovery. I think that's the most important thing that's missing. You know, some type of ongoing psychological treatment. And we are going to look at this type of psychotherapy here that should be used. Interviewing. Motivational interviewing is a psychotherapy technique which has utility in the treatment of opioid use disorders. The engaging, non judgmental approach and meeting the patient at their level allows for the therapeutic relationship to develop and the treatment to be a collaboration between the patient and the practitioner. And then there's also CBT, with this is individual therapy utilizing techniques found in CPT will be helpful in challenging the patient to explore the thoughts leading to the emotional distress and ultimately the self destructive behaviors associated with his opioid use. The focus of any therapies for the patient with opioid use disorder should be on maintaining abstinence while simultaneously developing healthy coping and life skills. All right. Let's go on to psychoeducation. And this is for the family. The patient and his mother should be educated about the side effects, risk, and benefits of all the medications utilized in the in home detoxification. They will also be educated on the use of cows to monitor withdrawal symptoms. But once again, I wouldn't put that on them. I would definitely send this patient residential or inpatient detox program. Once the patient has been opioid free for 7 days, he will be scheduled an appointment for the naltrexone injection, informed of the side effects, risk, benefits of this medication assisted therapy for opioid use disorders. He will be advised to carry a wallet card or wear a medical alert bracelet to inform others that he is prescribed and taking extended release naltrexone. He will be given patient education materials regarding naltrexone for extended release injectable suspension, which is the Vivitrol. So he'll get, a little pamphlet on Vivitrol. Additionally, the patient and the family will be given instructions on the use of naloxone or Narcan should the patient relapse and appear to be overdosing. The signs and symptoms of opioid overdose will be discussed with the patient and the family, and instructions for use of both the naloxone auto injector as well as the nasal spray will be provided. It will be emphasized that naloxone is only a temporary measure to allow time for the overdosed patient to be transferred to the emergency department for further care. Naloxone is not a cure for opioid overdose. Once again, it's short acting, it'll last a while, and then the person will go back into respiratory depression if he's not, taken to a facility. Um, and patient education materials will also be provided for this drug. So after listening to all of this, and you're thinking, you're going to put this poor family through all of this stuff here. It probably a better choice for him would have just been the Suboxone, the buprenorphine slash naloxone once or twice a day until he could really get into some psychosocial support system and treatment AA or NA or AA, and then you may be able to switch them from the Suboxone to the Vivitrol, because it just sounds like with all the responsibilities and the family dynamics, this patient's probably going to relapse, even if he makes it on the Vivitrol. I just don't see where he's not going to slip up and use again. So my thought would just be to give him a little bit of it ongoing, um, via the Suboxone. Does anybody think he? Does anybody disagree or with that?
I think that makes a lot of sense. I just wonder with the Suboxone, does anyone or like is that regulated? How is that regulated, or why would the decision even be made to not use it, or what? Like, was it actually up to the patient in this case? I was a little confused.
I was a little troubled by that too. Like I said, this may be a real case. It may just be a model case, but and I think the purpose of it may be to show us what the different options are. But I
Okay.
think most providers probably would have said no, no, just based on the patient's history, his family. Um, he doesn't have a job. He doesn't have anything stable in his life, so he's just gonna be fodder for his friends to, and his dad is his transporter to go get the drugs. So I mean, it's not a good look. Um, I would just I would just give him the Suboxone and say, hey, we're gonna be on this for 6 months, and then we're gonna
Hmm.
start looking at changing some of your lifestyle conditions and situation, and then see if we can get you drug free. I think that,
Would
and
that
I'm not. Go ahead.
would that be a normal kind of like time frame for the
I
Suboxone?
I would think so, and that may even be short. Because
Okay.
people's their lifestyles just don't. It takes a long time.
Yeah.
But and I'm a hardcore guy. I'm not really into maintenance therapy at all. I prefer detox and getting people off the drug, but you got to realize, you can chemically fix the brain, but psychosocially or psychologically, it
Yeah.
won't keep up with that fix. So you got to do all the you got to slow it down a little bit if you really want a solid outcome. All
Okay.
right. I'm checking the chat. Somebody did ask a question. Good morning. Is this patient a good candidate for at home detox? Because, yeah, yep. So, yeah, I'm already addressing this question. So, somebody already felt that at home detox was not good. All right. So, got a couple more things here and then we'll be done. This is a long case. I'm sorry if it's taking a little long. What standard guidelines would you use to treat or assess this patient? All right. They have they have medication assisted treatment of opioid use disorders. This is a smartphone app to support patients who use or plan to use medication assisted treatment with their patients diagnosed with opioid use disorder. It also offers evidence based treatment guidelines, ICD 10 codes, clinical support tools, and the Substance Abuse Mental Health Service Association, which is SAMHSA, treatment locators. It's available. Hold on. It's available through the App Store and through the SAMHSA and the SAMHSA.gov apps. So if you just go to samhsa.gov, you should be able to download this app. There's also the medication assisted treatment for opioid use disorder pocket guide. This is a free publication offering guidelines to practitioners using medication assisted treatments for patients. It's also available at SAMHSA at the store.samhsa.gov. So store.samhsa.gov and go to products, and then you'll be able to find this guide. And there's also clinical use for extended release injectable naltrexone in the treatment of opioid use disorder. A brief guide. Uh, this is also available at the store.samhsa.gov. And there's a SAMHSA's opioid overdose toolkit. And once again, this is available at store.samhsa.gov. So if you just go to store.samhsa.gov, they have various tools to help people set up a MAT program. Um, and here's a clinical note just to end this, and I may have time to do a few questions, a few cute questions and answers from my Q&A book. Um, Addiction is a disease of the brain. It is not a moral failing. Approach patients suspected of opioid disorders in a non-judgmental, compassionate manner. Focus on a patient's interest in becoming physically and mentally healthy. Partner with the patient and their families to support the patient's recovery. Individuals with opioid use disorders often relapse. It is imperative that the patient and family be educated that once a patient has remained abstinent for even a brief period of time, a relapse on a previously used amount of opioids may lead to an overdose. And the use of naloxone for opioid overdose will only offer a brief period of time to allow the patient to obtain emergency treatment through a local hospital. Medication assisted treatments for opioid use disorders should occur as part of a comprehensive treatment plan, including psychotherapies, 12-step facilitation programs, and medical oversight. And originally, uh, prescriptions for buprenorphine treatment was limited to physicians. However, nurse practitioners and physician assistants can now obtain waivers to provide buprenorphine, and information could be obtained from SAMHSA. Uh, Practitioners should be knowledgeable about buprenorphine as a treatment option, whether or not they are prescribing it. So there you have that. That little takeaway. I'm gonna do a couple of quick questions, and then I'll be done for today. Try to get my voice back. Let's see here. Page 33. Right. All right. We got a 29-year-old patient presents to the ER via EMS. The patient was found unconscious in a car parked outside of a restaurant. Um, on exam, the patient has pinpoint pupils, slow breathing, and cannot be awoken but with vigorous shaking. What is the most likely diagnosis? PCP intoxication, cocaine intoxication, opioid withdrawal, or opioid intoxication? What do y'all think? Well, it's opioid intoxication, pinpoint pupils, and he has slow breathing and trouble being aroused. Okay. What is the next step in treating this patient? We got five choices. We got administer IV diazepam, administer rectal diazepam, administer naloxone IM, administer buprenorphine oral, or administer naltrexone, which is Vivitrol IM. All right, we got those five choices. The correct answer is C. Uh, Administer the naloxone to block that mu receptor, and naloxone also comes in an intranasal, subcutaneous, or intravenous formulation. All right. Question 3: what is the mechanism of the medication used to treat this patient? A mu receptor agonist, a mu receptor antagonist, a GABA receptor antagonist, or none of the above?
B.
Yep, it's B. It's a mu receptor antagonist. And then, which medications are indicated for the long-term treatment of opioid use disorders? Choose all the correct answers. A. Vicodin. B. Naloxone monotherapy. C. Naltrexone monotherapy. Or D. Suboxone. And you can have more than one choice. So we got Vicodin, naloxone, naltrexone, Suboxone.
B and
We just,
D.
yep, yep. It's C and D. Naltrexone, Vivitrol, and Suboxone. Remember, in the case study, the the guy went to the clinic and they offered him two choices: Vivitrol or Suboxone. Th- in his case, they chose the wrong one. They should have just put him on Suboxone. But everybody got that. You can either
Yes,
you try.
thank you.
Uh-huh. 5. What prevents Suboxone from being abused? All right. I'll go over the questions here. Buprenorphine has no agonistic uh, effect on the opioid receptor. That's A. B. Naltrexone is a component of Suboxone, but it prevents it from being abused. That's B. C. Naloxone is a component of Suboxone, um, and it prevents it from being abused. And D, none of the above. So what prevents Suboxone from being abused? Buprenorphine has no agonistic effect on the opioid receptor. And I'll just break it down this way. Is that true or false?
False.
False, yeah. So that's not the answer. B, naltrexone um, is a component of Suboxone which prevents it from being abused. True or false?
True.
False. Remember, naltrexone is a Vivitrol. That's the other option.
Oh
It's
yeah.
actually naloxone is the component of Suboxone. All right, and then we go to distractor C. Naloxone is a component of Suboxone which prevents it from being abused. True or false?
True.
That's true. All right, so you got it. So we'll see. Naloxone is a component of Suboxone that antagonizes that mu receptor. And so you got a play between buprenorphine, which partially hits the receptor and satisfies it, but not 100% because you got some naloxone in there blocking it. So that prevents the patient from getting the high and preventing, a tolerance and a psychological addiction. So once again, in the case of the patient that we discussed, buprenorphine probably would have been the best choice. And then you could eventually look at full detox um, um, later. Alrighty. Uh, I don't have anything else. Does anybody have any questions about this case or the questions that we went over? I have plenty more questions, but my voice, I don't think it's going to take it. Um, but does anybody have anything else to talk to that they want to talk about or present?
I have a lot of questions, but I'll call you personally.
All right, then. I appreciate that.
Thank you.
Let me go get some cough medicine. All right,
Have a
then.
good day.
All right, then. Y'all take
Thank you.
care. Thank you. All right. Bye bye.
Thank you so much.